We just open some of the file which was sent with the MCQs pool. Before we were just open, we were just discussing about this rotameter shortly. So the question was about flow on the top. Okay. So anyone has read about rotameter? Anyone, please? Azhar, where are you?
I'm here.
Did you see the discussion which we were doing about rotameter?
Sir, not much in the books. Well, I can reply from my previous knowledge.
So actually, there. Let me open. Just give me a second. Let me open that. What's the problem with these? Because I'm being forced to discuss these questions with you. Though I again say that this is not the correct thing to do. Okay, I will again endorse this thing, but I will try to, because maybe not all of the questions I am having the fresh knowledge. I will try to help you out as much as possible. Just let me having the screen share. So if all of you will interact, then it will be more useful. Okay. So actually, what is the problem with it? These even if, for example, someone has this one open and just reproduce them. If you try to just, for example, if someone is frustrated that I have 1 month and I have 1 week and I have to understand, I have to just go through all questions, and of course these questions will come, and these are the statements which you listen, that sir, let us pass the exam and there is a lot of time for us to get the knowledge. Okay, so these statements of course are somehow they are having some weightage, but still who's having the exam just now? Amna, just please take the lead. Zainab, whosoever have the exam, just take the lead, please. Azhar, if you want to also, this question about rotameter, what are they trying to ask? With increased flow becomes turbulent, so density will increase. What does it mean? Yes, Zainab. Yes, Zainab.
Sir, well, may I reply, sir?
Yes.
So actually, they are asking the difference between the turbulent or laminar flow.
Yes.
When the increase, and or in other words, the application of the Hagen-Poiseuille's law.
Yes, actually the rotameter, that's why I just recalled my knowledge as well about rotameter. So the rotameter questions we actually discussed, but remember one thing, that when the flow is more, it's not related to height. Okay, it's not related to height. When the flow is higher, it's not height, it's flow. Because somebody is just tried to, just because of course when the flow is more, the bobbin will go up. So height will also increase, but actually it's not matter of height, it is matter of flow. When flow will increase, it will become turbulent and it will depend on density. That's what is the concept is. So for that, you should be knowing about Hagen-Poiseuille You should be knowing about Reynolds number. Can anyone recall the Reynolds number formula?
Say 2000.
No, Reynolds numbers formula.
Sir, it is Reynolds number is directly proportional to the density, length, and velocity, and inversely proportional to the viscosity.
Yes, if I can recall the formula, rho V over D. So V was velocity, rho was density, and eta was this one viscosity. Is it like that?
Yes, sir.
Okay, so actually I sent this about this rotameter. I just sent the. So if you read the page number as well, even I put it. So you will find a number of answer to a number of questions. Okay, so it's a constant pressure variable orifice. So this is a question which they can ask, that what is meant by this concept. Okay, then it should be anti-static, because if it is sticking with the sides of the tube, it will not move up. Okay, then there was another question that we have to read from the top of the bobbin, and from the center spherical bobbin, if it is, you have to read from the center. And if it is cylindrical, okay, vertical bobbin, so we have to read from the top. This may be one of the MCQ. Okay, then
Kindly repeat cylindrical or
spherical, if it is like sphere, it has to be read from the center of the ball. Okay, and if it is the normal rotameter, this, because circle is in less machines, majority machines have this bobbin. So if this bobbin is there, you have to read from the top. And if it is the circle, spherical, as they have mentioned here, you have to meant through the equator. Equator means the center. Okay, so this was the one point. And here they can like why it is conical, because as is go up, it is balanced by the flow, because as flow is going high, it is balanced. If it is not conical, it will become like a move straight. I'm not sure, I'm not able to, maybe I am not able to explain to you in a very nice way, but that is the reason that if it is it has to, because of the constant pressure, its design should be like that. The flow meter is designed so that at any given flow, the bobbin will reach at equilibrium position, where the force of gas moving in the upward direction is exactly balanced by the force of gravity acting on the bobbin in the downward direction. Like force is pushing the bobbin up and the gravity is pushing down. Okay, if the flow is increased, the bobbin rise up to the cone due to an increase in pressure between the needle valve and the bobbin. Because the flow meter is conical, there comes a point where the orifice between the bobbin and the side of the cone has enlarged sufficiently to accommodate the increased flow. I'm sorry, I cannot may explain to you in a very nice way. Just try to because I had read many years ago about it. This drop is in resistance to gas flow reduces the pressure on the bobbin, and the force in the upward direction is once again balanced by the force in downward direction due to gravity. Okay, if flow was cylindrical instead of conical, opening up the needle valve to deliver even a small flow of gas would lead to the bobbin shooting out. It will run away. Okay, akin to a pea shooter. If anyone has the idea to explain in it in a better way, otherwise we will go to the next question. Just a second. Okay, asked for name of device used as oxygen analyzer, CO2 and anesthetic gases. There are actually two sort of analyzer. One is paramagnetic. Paramagnetic is for oxygen, and it is for the gases which has two similar atoms. You know about paramagnetic and infrared. So infrared is for gases with two dissimilar atoms, like in any other gases. Okay. So that is for other one. Actually, I can open that book. Just let me open, because you know what is the problem, that there is no if you don't have the concept. I have very weak basic sciences. I apologize for that, but clinical questions I will try to have in a better way. But if you want to understand, I can just help you in that how you have to measure, how can you do the troubleshooting. Just a second. Delivery of anesthetic gases monitoring. I think it was here. Okay, so that is what they are telling you. Are you people are with me? Are you getting? Yes, and because if you will
Yes,
speak,
you are with you.
yes, Azhar.
Yes, sir. Yes.
So this was the question which they had asked: our name of device used as oxygen analyzer, CO2 and anesthetic gases. So I don't know what they are trying to ask in this question, but here you see, for measuring oxygen, pulse oximeter, this jugular venous, and in a gas, in with fuel cell, paramagnetic analyzer, and mass spectrometer. There are different working principles for these three things, and if it is in a blood sample, it is through Clark electrode. Okay, so these are the devices which can measure the paramagnetic gases. Only those will be measuring which can measure the paramagnetic gases. Okay, so this may be a part of MCQ which they were asking you. Pressure gauges. I will just show you the. It is from here. I sent you this short screenshot. Okay. Of course, we are not discussing in detail, but you see that fuel cell. This is in the oxygen sensor which we use. Okay. So that is in modern anesthesia machine, there is a fuel cell galvanic oxygen analyzer that measures oxygen tension. Okay. So it is as a part of monitoring. Okay. This one is fuel cell. Infrared gas analyzer for all. What is the working principle of end-tidal CO2? This is also infrared gas analyzer. Okay. Is the method by which the anesthetic measures the partial pressure of volatile agents, nitrous oxide, carbon dioxide. Okay. The pressures are used for molecule that consists of two or more different elements absorb infrared radiation, but those that consist of only one element do not. Okay. So therefore, in anesthesia practice, the infrared technique can be used to measure CO2, nitrous oxide, volatile agents, but not for oxygen, nitrogen, or helium. You understand this concept? So any question, if MCQ comes like that, you can answer it. Okay. But for example, my dear friends, if you want to take benefit of this paper, you can get the benefit, but not in that way. That if you just read this, just please just feel free to answer. Just tell me how many, just honestly speaking, how many people explore like this? Just tell me honestly. I want to listen from you. Aksa, please tell. Azhar, don't tell because I know about you. Aksa, Amna, Zainab. You know, if you will not speak out, there is no advantage of me wasting my time. Please speak out.
अस्सलाम वालेकुम सर सर जब अगर आप खुद से करते हुए ऐसे करो तो it takes a lot of time, honestly speaking.
Just tell me
and
one
the point
thing.
is the with
Just tell me one
I do
thing.
not do that.
Take a lot of time. Even then,
No.
Is there any shortcut? Tell me honestly.
No.
If you don't do it,
But sir,
you know, there is
Okay,
some,
I'm willing to do this, but the point is कि जैसे अब एग्जाम सर पे आ जाता है और फिर उसके बाद सबका
Aksa, I apologize to Mr. Jennifer Rose. We will just try to communicate English. And, you know, she's saying that if we have short of time, what should we do? I tell you something, that there is no
Okay,
shortcut. Okay, Aksa, if you want to understand, this thing you will do forever. You will never stuck if you study in that way. And another, because this is a moment to send this message to all of you. Why you people are in hurry of appearing in IMM in right after 2 years? Just tell me. I just want to understand.
Okay, okay. Even if we take some more time, so
Yes.
it gets you, you know, so stressed that everyone else has
No.
done the thing
No,
and
no,
you
this is,
are still stuck at the same point. So you start questioning yourself that it's because something is wrong with you, you are not putting enough
no.
effort.
Aksa,
So
you
such
know,
kind of things.
no, Aksa, I tell you something. Maybe you are not hearing this thing from people around you. Unfortunately, they should be telling. What is the purpose of intermediate module? Intermediate module is the dress rehearsal of the final exam. It is not like a fashion. It's not like a something. It is just like to evaluate you. Are you on the right track or no? Okay. So if, for example, if you understand the reading, you take your time. Not you should not be hurry up. You should not be in hurry. Okay. There is no advantage of passing the exam without any knowledge. I passed my intermediate module in first attempt, and I suffered like a hell in my final exam, because I passed it only on the basis of practical experience. I know in little information, I passed the exam, and that was the biggest source of me failing in the final exam. Because maybe if I had failed in intermediate module, maybe I would have vacant and I would have studied. So please try to understand this thing. There is no way you can bypass the things, because what will happen? Even if, for example, you do all these recall questions, there will be some other questions. And another, tell you something. If these red marks, whosoever Waliullah has made this paper, I salute to him. But actually, he is damaging the futures. Whosoever has put it. Because the thing is that, yes, if you utilize this thing, what will happen? You will do 10 questions, 15 questions, 20 questions. It will be more beneficial, Aksa. If you are appearing in the exam and if you have no idea, you actually should not appear. You understand my point? And that is the only...
Sir, I'm not gonna sit in.
Sorry?
I'm not gonna sit in this. I'm gonna sit in February attempt.
But you
I
understand.
am just
But
listening so
please
that
don't rush up. Even if you have to study for one more year to finish the course, you should not hurry up. Because if you try to bypass it, you will not be an advantage. Okay. So the next, you understand, that's what I wanted to show you. I'm just giving you a hint how to find the answer. You can use this book for any monitoring equipment. You will find the answers out of it. Okay. And there is a concept of infrared, there is a concept of paramagnetic, which you will get from here. You will find no need to read each and every line. Just try to understand what is the working principle, what is the use, what is the overview, what it is doing. Okay. Because you will be able to answer the question if you understand even that much. Okay. So, but you should be knowing, because calorimetric analysis, you are doing it for in the same calorimetric analysis is being done for calculating the this one as well, nutritional requirement, calorimetric analysis. Okay. So I'm just showing you, you can have a look at it, and you should be knowing 1-2 points about it. Then you will not miss any question. Okay. Now next question. Allowable current leak less than 10 milliampere or microampere, select correct. For macro shock, 100 milliampere causes fibrillation. Microshock does. Anyone got any idea about it? I will just try to find out.
Sir, actually this question is asking the allowable microshock, and this is different for the different site.
So actually here you will find the answer, because this is one of the weakest topics for me. I always forget Okay, so this is the macro shock, I think. Okay, this is the macro shock. So 100, you will have fibrillation. Less than 1 im, it is not feel. 1 tingling, 5 is painful, 8 causing burn, 15 tetany. Okay, skeletal muscle let go phenomena. This is called as let go phenomena. Like if this is much is current is there, patient will not be able to get away from the current. Okay, and then in 50 and 100 you will have this skeletal muscle and this one. Okay, so when a current of 100 milliampere passes from one hand to the other hand, only a friction less than 1 actually passes through the heart. So the heart directly to the heart will be 1%. Okay, so maybe you will find the answer. So what was the question? We will just see it again. For macro shock, 100 milliampere causes fibrillations. Okay, micro shock is 10 milliampere. Let us confirm this micro shock. Equipment that is made to be inserted into the body is classified into a further groups, because I have forgotten everything about, so I have to read about it. So this one you should be, because in some MCQs, have you ever faced this question about the type of equipment? Anyone, please? Azhar, did you see any question like that?
Sir, in certain MCQ
Yes,
books,
yes, sir. In the previous MCQ,
there was
there is
question.
a question.
Okay, so type B equipment has a maximum leakage of 500 microampere if used with a class 1 safety technique, or 100 microampere if used with class 2. I think class 1, class 2 is these one for macro shock. Class 1 requires that any part that can come in contact with the user is connected to an earth wire. This forms the third one. I'm sorry, I am not able to explain to you, so better not to waste time. You can read it from here, you will find the answer. But macro shock is 100 milliampere. I will read it. I will have to prepare this topic before discussing with you. But this is from here where you can get the answer for this MC. Okay, let us find. Yeah, defibrillation joule. It is 2 joule per kg. I suppose it is 4 joules per kg. What do you think?
Sir, it's 2 joules per kg, sir, I suppose. Can anyone please confirm?
Because there will be 2-3 things, whether it is biphasic or monophasic. Because usually we in adults we are giving 200 joules biphasic. Okay, so that you can say 2 joules per kg roughly. But if it is
ਸੁਬਾ ਹੈਂਡ ਫ੍ਰੀ ਲਈ ਸੀ ਤੁਸੀਂ
if you are talking about biphasic, it is 2 joules per kg. If it is monophasic, I think it is 4 joules per kg. Okay, CSF formation. Just a second, I will show you the picture for CSF formation. Okay, so if you want to answer this question in a,
May I say something, sir?
yes.
Sir, a CSA formation as far as CPSP is concerned, this is a constant and common question to be asked. Probably they have, I don't know, I'm not sure, but whether they have incorrect key or what, I'm not sure, but it is said that formation per hours. So usually 21 mils per kg per hour is the formation, normal formation. So they clearly convert to either in 24 hours or 1 day or like that.
It is around 500 ml per day.
A day. Sorry. That means 21 mils per hour, sir.
Yes, but here they are telling about the formation. Okay, that is the rate. So you should be just knowing about the rate. Actually, it is in the many books, but it is written in a very nice. I'm just trying to rush up with the things so that your time is not wasted. But for that, you know, you will find it here in this
Sorry
book.
to say that you are doing same our mistakes, sir. We are rushing up the things and you are following it. Otherwise, you
Yes.
say they don't follow, don't rush it.
Yes, very nice, very nice. So, this one here is the CSF question. I think this one, 319.
See, sir, what is really asked? There are 2 or 3 things about the CSF: rate of formation, CSF in the subarachnoid space, and how is it absorbed. This is what what I can say, that the CSF question is must to become in the CPSP exam. That is must. One times they ask the rate, sometimes they ask the volume, or like that. They just roam around the CSF,
Yes.
or one way or the other way the question is asked.
So actually, you see, it is produced by the choroid plexus of lateral ventricle. Passes the MCQ will be on this chart. If you know, you can answer. From lateral ventricle to third ventricle is foramen of Monroe. From third ventricle to fourth ventricle is Sylvian duct, and for fourth ventricle to spinal canal is Magendie and Leschka. Okay, and absorbed by the arachnoid villi in venous sinus. This is the for the production and absorption, and the rate which you were telling was it's that one. Okay, in the different way, the total volume which is there is around 150. Okay, and production per day is 500 ml per day, or 0.35 ml per minute, or as you were saying, you can multiply it, so it will be around 21 ml per hour. Okay, these are all one and the same things. So I will highly suggest you, even if you are busy in doing these holy verses, spend some time in this, some nice things. I know that people will be smiling at my comment. No, sir, you are downloaded from internet. So you talk something out of the world. We are in Pakistan. We are in Pakistan system. So mind it, I am trained in Pakistan. I have faced CPSP like a hell. I have been trained in the same, I apology for the word, in the same rotten system of our country. And I have passed through it, because now if any senior listen to my comment, they say you have come through this thing, you have learned, and now you are so using these your bad words. I'm not saying it for blaming. I'm just trying. That's what I'm trying to do. That please come out of that system. If you will do it, maybe like Aksa, you told that you are appearing in February. I will suggest you to appear in August, next August. Take your time. No, don't rush up. There is no advantage of bypassing it. But if you read in a proper way, inshallah, you will pass. Okay. So next question, what is this? Acute trauma. Among all options, most appropriate was no increase in ICP. Inna lillahi wa inna ilaihi raji'un. I don't know what is this question. MCQ regarding aldosterone excess and regarding its deficiency. So what is the mechanism of action of aldosterone? Anyone, please? Where is it acting?
Aldosterone acts on the distal collecting tubules and increase the absorption of sodium and water, and increase the excretion of potassium.
Potassium and another thing, hydrogen.
Hydrogen, sir.
Okay, so that's why it will cause, now you can say over here, it will cause alkalosis and hypokalemia. Okay, and deficiency will cause hyperkalemia and acidosis. Okay, so whatever they have written is right. But if you understand that if they are absorbing sodium, they are pushing out potassium and hydrogen. Okay, so this is what is will be asked. Okay. Okay, patient with glucocorticoid deficiency patient. So actually this question on the glucocorticoid replacement. So you should be knowing the equivalent doses. So 5 milligram of prednisolone is 0.75 of beta-methasone and dexamethasone, and 20 milligram of hydrocortisone and 4 milligram of methylprednisolone and dexamethasone. I think this is not 8. Methylprednisolone is active. Just reconfirm. Please mute your mic. If you are not talking, please mute your mic. Just a second. Should we search for it and or should we go for next question? Everyone knows about it, I think.
Yes, sir, we should go to the next question.
We
Sir, the table in the Branny Hall of fecal and
just a second. Okay. So I think this was written wrong. Okay. So it is right. I'm sorry that I forgot it. I thought it is 40. Anyways, so it is 20 milligram, 5 milligram, 5 milligram, 4 milligram, 0.75. So there was one more, I think beta-methasone is dexamethasone, same, and methylprednisolone. Anyways, that's how you know we forget the things. Anyways, next question. Okay, so this question is a clinical question. So please try to even if you see the same question, try to understand. Try to understand what may be the scenario. But basic thing, remember, fracture is never elective. Fracture needs to be fixed. So you cannot defer. So this answer is finished. Now brachial plexus block, why it is finished? Because if you already have pneumothorax, they may be at risk if you give brachial plexus block with because for humerus, you cannot do axillary block because you need a higher like upper trunks, you also need to be blocked. So for humerus fracture, axillary block will not be a very good choice. Okay, and maybe it will be difficult to perform, and so that will that is also out. GA with nitrous oxide, GA without nitrous oxide, do chest intubation, then proceed with surgery. Among these options, that seems to be the best answer. But remember one thing, with nitrous oxide, what is the problem with nitrous oxide? With or without nitrous oxide? What will happen?
Pneumothorax, sir. Increase in pneumothorax.
Pneumothorax.
What pneumothorax? Dr. Humera, whenever your comments come, your comments is just like a sound. No proper answer. Pneumothorax will in size will increase. So say like that.
Increase in size of nose.
Thank you. Okay. 40-year-old on beta blocker, intraoperative, sudden heart rate drop to 50, BP to 80/40, which drug appropriate? Actually, according to Dr. Naveed, salute to Dr. Naveed because he has told the correct answer, but may not be the first choice. If you have to see the different options, because you know why you should be, this answer should be on the basis of basic life support algorithm. Okay. So bradycardia algorithm, not basic life support, bradycardia ACLS algorithm. Okay. So if first line drug is not acting, and of course when the patient is beta block, atropine will not work. So atropine will not be the first. Maybe they have given some doses of atropine and it is not responding. So then you will go to second choice. Okay. So the answer will be according to the scenario. Can you mute yourself, please? Vivo 1901, please mute yourself. I'm sorry. I'm being distracted by these sounds. Okay.
Sir, I have a question, sir.
Yes.
Sir, if the scenario is in this question is the patient is taking beta blocker, but if in the scenario the patient would not be taking beta blocker and the same scenario came, then we will use atropine or adrenaline, sir.
Just tell me one thing. What is the bradycardia algorithm ACLS says? This is not by words of me, Heather. Okay. So try to understand the concept that in this answer, the answer is in this question, answer should be on the basis of ACLS algorithm. Okay. So you have to follow the ACLS algorithm. The answer is this one. So what is the first choice in ACLS algorithm?
So in ACS algorithm, if the patient is bradycardic and there is hemodynamic collapse, then the first option is atropine, sir. 1
So
mg IV.
thank you very much. That is the answer. Okay. Because this is the one. Maybe it is not the latest one. You have to follow the latest one. In the second choice, it is dopamine and epinephrine. Okay. So dopamine may be used, epinephrine may be used. If the option if it has both, this is a question. Okay, because they have written or. So a good examiner should not give both epinephrine or dopamine. But if both of them are coming, I have no answer to that because they have written or. Okay. So, or for example, if again, even if you are giving epinephrine, you have to prepare for transcutaneous pacing. So that is the answer in discussion. But in the MCQ, they will give some hint what they want from you. Okay. You got my point?
Yes, sir.
Okay. So first line is definitely atropine. And then you will go to the second line. Okay. So this is the answer. Okay. Next. In this options, answer should be epinephrine. If we only these four are the options. Okay. Because there is another reason, because both heart rate is less and blood pressure is less. So this makes an even more indication of epinephrine. Okay. So formula for factor VIII, all of you know. Okay. I don't recall the formula, but you know about it. But the point, we should be knowing it, that if you want to replace, what are the different options for replacing factor VIII?
Sir, for factor VIII replacement, we have cryoprecipitate, factor VIII, concentrate, and FFPs.
So start from factor VIII, then cryoprecipitate, then FFP. Okay. Because the most concentrated, the least ml of volume you need to give is factor VIII, then cryoprecipitate. So they can ask you in this question, I don't remember, there is that how many mils, how many units are there in 1 ml of concentrate, 1 ml of FFP, 1 ml of cryoprecipitate. Okay. Okay, how to calculate amount of glucose absorption through kidneys? I'm sorry, I don't remember this formula. If you want to learn this question, learn like this. Glucose absorption formula. I think this is the formula. 1 by dt or do. What is 1 minus dt or do? Have you probed this question? Daily glucose absorption was calculated by multiplying d1 minus dt or do. What is this? dt or do? Anyone has got any idea about this dt do?
No, sir.
So I'm just bypassing it. I have no idea about it. Okay, what is the question then? How to calculate sodium deficit? Values were written. It is again, the formula is, so that's why actually yesterday when I was telling, you should make a list of all the formulas which may be used. Okay. make a list of formulas, make a list of, if you listen to the yesterday discussion, you will benefit. I just explain a number of things. I will highly suggest you people to listen. Okay. Chloride shift. What is chloride shift? Can anyone explain? Yes.
So basically, chloride shift happens during the exchange of carbon dioxide and hemoglobin to maintain the electron neutrality of the.
It occurs at
RBC.
periphery or the lungs.
Periphery.
Sir, in lungs.
Lungs. Okay. It occurs in lungs, on the lung side, because CO2 is taken up. To maintain the electron neutrality, chloride comes in. Okay. Okay. If oxygen is increased in atmosphere 3 times, dissolved hemoglobin, 3% increase in dissolved hemoglobin, not dissolved hemoglobin, dissolved oxygen. Okay. What if it is 3 atmosphere? You understand this question? The pressure
Yes, sir.
has effect on the dissolved oxygen, which is actually minor portion, and we use this phenomena in treatment of which condition?
This
Carbon
one.
monoxide poisoning.
Carbon monoxide
Yes.
poisoning, gangrene,
Gangrene.
anastomosis, skin grafts, things like that. Okay. Okay. There is no new electrocautery in OR. What will you guide CSSD regarding safety? I have no idea about it. Some about electrocautery. What are the points you should be knowing about diathermy?
So we should be knowing about the types of diathermy, that how many types of diathermy are there, monopolar or bipolar.
Very
We
good.
should know the working principle of the. We should know the working principle of the diathermy. That the current is dispersed, like the density at the point of giving the current is very large, and then it travels to the body and goes.
Yes, actually, if you want to have a quick review of basic sciences, this book is excellent. Okay. Master Pass, page number 180.
Electrocautery, one is coagulation mode, one is cutting mode.
Your sound is gone. Please speak loudly. Your voice is gone. I think there is some problem in your voice, please. You see, it is a high frequency alternating current. Okay. And this is causing heat, and either it is cutting or coagulation. Okay. Cutting mode, the current flows in alternating sine wave pattern, and in coagulation mode, current flows in pulse sine wave pattern. These are MCQs. They ask this thing in the MCQ. Okay. One is monopolar and one is bipolar. So bipolar, there is the passing through the same forceps. They have the both poles. Current flows through a probe active electrode at a high current density, and then returns via diathermy plate at low current density. Okay. The overall power that can be delivered is in the region of 100 to 400 watt. And this has low power, so it is better to be used in patient with pacemaker and things like that. Okay. So it's a better technique. And why is the diathermy band always checked at the end of surgery? Because if it is not properly attached, there may be burn. Okay. because that is the exit point from through which from where the current is coming out. So current density means the place where it is coming, it is very concentrated. I'm just trying to explain. Okay, so that place it is causing the burn or coagulation, or if you are using for cutting. So these are the MCQs which they can ask you about. This one. Okay. So next question. Methemoglobinemia. What is methemoglobin? Anyone, please?
So usually in HP, the iron is in two forms, the Fe plus, basically one form, Fe plus 2. But due to some reaction in the body, if the condition is changed from +2 to +3, the ferric, then the condition is known as methemoglobin.
Very good. And it is pulse oximeter cannot pick it. So it has both the same absorption spectrum. So it is showing 85%. Okay. Am I right?
Yes, sir.
Yes.
And what is the treatment? I forgot the reaction, but if it is occurring as a result of something, the methylene blue is being given. Something like
So
that.
methylene blue is
Yes, sir.
methylene blue is given.
Okay. And prilocaine, what about benzocaine? I don't know why they have written benzocaine. Prilocaine causes
Sir, because both of them cause
benzocaine
methemoglobin.
also cause methemoglobinemia, because I only
Yes,
remember
sir.
prilocaine.
Yes, sir,
Both of
benzocaine
them.
also causes.
Okay, fine. While inserting pulmonary artery catheter, you notice sudden hypotension. Most appropriate. Hemorrhage, arrhythmia, tension, pneumothorax, hemothorax. Okay. Sudden hypotension. What may be the reason? Is it arrhythmia or hemorrhage?
Sir, most probably it is arrhythmia during passing the pulmonary catheter.
Okay, tell me one thing. Again, when they have whosoever will make this question, there will be some hint. Okay, there will be some hint about it. If, for example, they have told only during inserting, like they have written here, so arrhythmia is option. Okay, but for example, if they had given a scenario in which they are taking the measurement, then hemorrhage. Okay, because when they are taking the measurement, or if they are inflating the balloon, that time pulmonary artery can rupture. You understand?
Okay.
So yeah, so this is a small point you should be knowing about it. So the hemorrhage, if it is yes, Tayyab.
Sir, in previous scenario, cardiac tamponade can be an option.
Cardiac tamponade.
Sudden hypotension during insertion of catheter.
Tayyab, it will not be very sudden.
Okay, sir.
And if, for example, even if it is here, hemorrhage will lead to tamponade, like it can lead to tamponade like effect as well. But actually, if these are the option, the answer will be hemorrhage in that scenario. Okay. But
Okay,
during insertion, because of arrhythmias, patient can have sudden hypotension. Okay. Because when they are inserting, it is not, you are not, like, for example, again, I tell you something. When you will find the real-time question, they will definitely give you some hint. It is not possible to give you without hint. Okay. Okay. Patient with ST depression, short T wave, U wave, potassium was not given. Refractory hypokalemia is due to hypomagnesemia. That's why I marked decreased magnesium. Don't know for sure. What will be the ECG finding in hypomagnesemia?
Sir, one is QT prolongation.
Okay. I don't remember the exact finding, But I tell you something, that there will be some hint. Of course, potassium, if you want to correct potassium, you have to correct magnesium as well. Okay. So this is because of some ionic channels. I forgot exactly the reason, but you have to correct magnesium as well. Okay. So with this may be the reason. 20 kg, what with 50% of burn. Total body water in 24 hours. Yes, this is Parkland formula. 20 into 4 into 50. Okay, MCQ regarding a child, what will be his total volume requirement in 24 hours? What is this? How will you calculate it?
4 to 1.
4 to 1. Okay. They will give some weight. Among all, which drug can be given in patient with COPD? All were beta blocker and three were beta 1 selective. MCQ from Brian A. Hall. Okay. Metoprolol or acebutolol. Metoprolol or atenolol are cardioselective. Yes. Actually, in this scenario, they would like to have a beta blocker with inherent, what is that called as? Inherent beta mimetic.
Sympathetic activity.
Yes. So I think this is acebutolol, if I'm not wrong. Okay. Okay. 6 months old infant, lumbar region spinal applied, first sign of local anesthesia, overdose. Is it bradycardia, hypoxia, or hypotension? What is the answer? They have written the correct answer, but why? Why not bradycardia?
Sir, I think that before
Tachycardia.
hypoxia leads to bradycardia. That's why hypoxia is the first event.
Why hypoxia?
And
I
central
think
respiratory
because
system depression.
Please, one person speak out, please. Say it again, please. Heather, please, you were talking. Or Farzan.
Sir, yes, I was saying, sir, the hypoxia is due to the central respiratory depression leads to hypoxia, and which later leads to bradycardia.
Okay. Because this is a question which is asked a number of times. Okay. You should be knowing. Just a second.
Sir, first there is respiratory depression and then comes cardiovascular depression.
No, but
according to plasma level of local anesthetic.
no, but here the question is not the levels. It is related to what happens in pediatrics.
Okay, sir.
Because in pediatrics, the cardiovascular responses are not as in adults. Okay. So hypoxia is the first sign. Okay, spinal block applied, most important factor for level of block achieved. This question is asked multiple times and I don't have the correct answer. They have written varicity. Varicity is, I don't think so. It should not be the level. For level, it is the dose. I think it is the dose.
Or the position, sir.
Because varicity is related to the position. Okay. So if they are asking you, there should be some reason for it. If, for example, the same varicity can cause low level if positioning is not properly done. You understand my point?
Yes, sir.
So while you are answering this question, you should be should be reading the stem, because the stem will tell you the correct answer. Okay. Yes, Dr. Farzana.
Sir, can't it be the drug volume and that may affect the level of block?
No, volume, how? Volume may be diluted. Volume is not. You understand? Because volume may be diluted. If you are giving 10 ml.
Yes, sir.
And they are not talking about
But
epidural.
if the volume is high, it can reach up to a much higher level, sir.
It is about spinal, not epidural.
It is not about us. That's what I'm saying. This is more if effect is more in epidural volume. In Pakistan, we are using 0.75%. Am I right?
0.5 also, sir.
So in Saudi Arabia, 0.75% is not available. We always have 0.5%. So I don't find it different. Okay. So I think in this question, either it is dose or it is velocity, because actually all factors are important. Volume is also important in some way, but it is more important in epidural than in spinal. Because why it is so? Because you already mix the dose. You are mixing it with the fluid. In epidural space, there is no fluid. Am I right? So volume is not that much important in spinal. Okay. You are giving. Yes.
Sir, in spinal, velocity and position matters more, and in epidural, it's volume for the level of the block.
Yes. Okay. So that's. I hope you understand, Dr. Farzana.
Okay, sir. Thank you.
Okay. So what is the next question? Maximum risk of endobronchial intubation in which position? You see, head flexion, Trendelenburg. What would you say? I would say Trendelenburg, not head flexion.
Sir, I think this is right.
How?
When there is a head flexion, crina will come up and there are chances of endobronchial intubation.
If you are doing head flexion in reverse Trendelenburg position, will it have the same effect? Because when they do the Trendelenburg position, all the diaphragm is pushed.
Yes.
Okay. When we are making the head flexion, what is happening?
Sir, tube is pushed downwards, more downward.
Actually, we just, because both answers are correct. It is Trendelenburg as well as head flexion. Now we have to choose which is the best. Okay. I think Trendelenburg effect should be more. But I'm not sure, but I don't know. Head flexion, because you know how much will be the effect with this one. So I have no idea which should be in the in their key, because they will give some hint. What do you think, Azhar? Anyone, any other option, any other person, please? Yes, please. I will confirm and I will tell you, because in my opinion, it should be Trendelenburg. Okay. Let me just think about it. Okay. Maximum risk of brachial plexus injury in which position? Lateral decubitus, because there will be pressure. Am I right?
Sir, am I audible, sir? May I ask?
Yes.
Sir, actually, regarding the endobronchial intubation, this is a common question. in the flexion, once we flex, there is a chances of endobronchial intubation. And with the extension, there's a definitely tracheal intubation. This is vice versa, sir.
No, you are right.
For sure, I'm sure that this is endobronchial for the flexion of the neck.
The answer is flexion of the neck. Okay. Actually, we have to compare influence of head flexion after intubation. How much it is moved. We have to compare because they will be the because actually such questions are actually really very confusing. Okay, has significant effects on heart rate. So after endocrine can be yeah, they are seeing the this hemodynamic effects. Anyways, let's see how much it is effect, because Trendelenburg position also do it by pushing the diaphragm up. So we have to compare which has more effect. Either it is a head flexion or Trendelenburg. Okay, patient on PCO morphine, demand 72, bolus 1 milligram with 10-minute. Actually, this question, they want to increase the dose. Dose is never 2.5. It is actually the lockout time in this scenario. The lockout time is 10 minutes. So they can decrease the lockout time to 6 minutes. So it will be giving because they are putting too much demand. Okay. So in my opinion, it should be the lockout time first and then dose. Is it someone has read this MCQ in Braine Hall? Yes, please. Anyone?
Yes, sir, I have read it, sir. Basically, in that scenario, they're asking even after giving the preset dose of morphine to the patient still complains of pain, and his rate of infusion has morphine he has maxed up his dose, which was preset on the PCA. So the answer was to increase the dose in the setting of this infusion, sir.
Actually, the scenario will tell. Okay, because if they have mentioned the lockout time, this may be an also option. But if they have mentioned the dose, increased dose, because maybe they will have so many options. There should be some data about it to understand the answer. Okay, because the more important thing is maximum hourly dose. Maximum hourly dose may be increased by both the dose as well as decreasing the lockout time. Okay, frequency will also have that effect. So if you increase the frequency of the doses, this will also have increased the dose. So maybe I'm not sure about it. Again, the complete scenario can tell the answer. Patient with porphyria, which opioid should not be used? Yes, it is pentazocine. You should be knowing. Yesterday I was telling the same thing. Drugs safe and or unsafe in porphyria. Drugs prolonging QT interval. Okay. So I will also, these two questions I will confirm and check, let you know. This endobronchial intubation and this question. Femur fracture, now in IM nail hyperemia on right side of chest after intubation, now difficult to ventilate. Bronchospasm, pneumothorax, secretion, hot embolism. This should be bronchospasm, no? Because it is a sign of reaction, difficult to ventilate. So it's not pneumothorax. What do you say? Yes, Zainab.
Sir, in the question, they have said that there are fatigue on his shoulder hyperemia. That clearly, like that, it is one of the most important sign for uh, fracture
Fat
bone
embolism.
embolism.
Yes,
Fat
so
embolism,
it
yes.
may be fat embolism, but it may be bronchospasm, not pneumothorax. Pneumothorax should not be the answer. What do you think? If someone has said, because you see, if it is hyperemia, not petechiae, hyperemia and petechiae are different. If it is only hyperemia, maybe it is, like for example, a condition like rash-like condition. Okay. So if it is not fat embolism, written, not written, then bronchospasm because of reaction. A patient with 3 centimeter cervical dilatation wants pain relief immediately. Best choice, single shot, low dose epidural, CSC.
Epidural, sir.
Epidural should be the answer. You see, if it is more dilated, then CSE, like in the sense that you will be giving a saddle sort of block. Okay, so then it will be, but it is 3 centimeter. I think it should be epidural. Yes, any comments on this question?
I think, sir, epidural is okay.
You see, the only thing which is confusing, or which may be that they have written immediately, because epidural will take some time. So if they are asked, maybe if they have read the whole scenario, then in that the thing which is making it fishy is this immediately. Okay.
Sir, I
Because
was reading this other MCQ. In that MCQ, morphine was also in the option. So if the question is
It
asking
is
about
there.
immediate, so morphine.
Morphine is written here in fourth option.
for porphyria,
No, in this scenario, the fourth option is IV morphine. Check in next page.
yes. Morphine, morphine will not give immediate pain relief. How morphine still takes 15 to 20 minutes for its effect. Okay. Morphine is less lipid soluble. Morphine does not take effect quickly. Okay.
Then it means CSC is right.
Yes, CSC may be right. It will depend on the scenario. Again, I tell you that they will give you, they have written as the best option. So best option may be CSC. But the thing is that in what should be given in spinal, because usually in CSC they are actually I have no idea, because I have never used CSC for labor, so I am short of ideas. But maybe this is the hint that they have written immediately, so CSC will gets effect quicker than epidural. IV morphine will definitely be no, either it is epidural or CSC. Okay. Patient with uterine rupture with epidural already present. Best choice for anesthesia. They should be writing the vitals or something like that, but general anesthesia will be a better option. Okay. Patient with liver failure with which coagulant most affected? Vitamin K dependent. If they have written like that, then it will be vitamin K dependent, but which factor has the shortest time?
7, 6 hours.
Yes, so factor 7 should be there. Okay. So patient with traumatic brain injury, which most? Cerebral perfusion pressure, not 50, 70. It is wrong. It should be 70. It's not 50. Patient with traumatic brain injury had to calculate GCS. GCS you should be knowing. Patient with traumatic brain injury scenario was of diabetes insipidus. It was diagnosed on the basis of sodium and osmolarity mentioned. So what happens in diabetes insipidus? Actually, there is too much free water loss. So sodium concentration is increased. So this may be the answer, but maybe the other things they can ask you about it is about whether it is nephrogenic or this central diabetes insipidus. Okay. Patient with traumatic brain injury started ER on mannitol. Electrolyte and osmolarity were mentioned. Most possible cause. Most appropriate answer was mannitol. How? I don't know what is this answer. What is this question? No idea. Do you understand anything about it? What they want to ask?
Sir, in anesthesia, I have read that mannitol should not be started in ERs. Patient should be given first aid, and then surgical team, neurosurgery team will decide to use mannitol when they are handed over to neurosurgery department.
Yes, mannitol is not to be given. Other factors will be, again, you know, this question you should be reading the whole scenario. Okay, 3-in-1 nerve block they have written rightly, femoral lateral. Patient with hyperkalemia now showing tall T waves. Best treatment. Calcium gluconate is not the answer anyways. Okay, if it is that, then it should be calcium chloride. But there should be some scenario. Okay, they will give you some scenario. Because even Lasix is correct, insulin with dextrose is correct. Calcium gluconate, not the best treatment. It is not treatment. It is just to prevent from arrhythmias. So this answer question, have you got clear concept about hyperkalemia? When you are treating hyperkalemia, the management is that you will be stopping any source, whether it is oral, whether it is IV. This is one. And then you are giving from oral route chelating agents. 2. 3, then you are, if it is acutely, then you are giving, first of all, you are trying to put it, this one inside the cells. For that, you are giving insulin. For that, you are giving beta-2 agonist to do the trans-compartmental shift. So beta-2 agonist will also be given, nebulized, beta-2 agonist and insulin. And then you are throwing it away by giving furosemide or dialysis. Okay. So this is, and calcium chloride and calcium gluconate, whatever it is to strengthen the heart from the arrhythmogenic effects of high potassium. So this is the whole concept of management of hyperkalemia. So if they say that you want immediate management, so actually the transcompartmental shift should be the answer. So in that scenario, insulin with dextrose or beta-2 agonist should be the answer, because it will move the transcompartmental shift. If they are saying that only tall T waves, it will depend on the levels. Okay. So I don't think so calcium gluconate should be the correct answer, because among calcium chloride and calcium gluconate, calcium chloride is more effective. So if you want to immediately have good ionized calcium, you should be giving calcium chloride rather than calcium gluconate. Okay. So easy MCQ answer was aortic stenosis. He doesn't want to tell you the scenario. He is only telling that if any scenario of syncope occurs, you write aortic stenosis. Really, anyways, you are replaced by short waves, then again P wave and QRS observed and no regular interval. I don't know. See, I'm sorry. You should be knowing VFib. How will it look like? Okay. Short waves, then again P wave. I don't know this. If it is like that, apparently it looks like atrial fibrillation rather than ventricular fibrillation. Okay, they are just trying to say that again P wave, QRS observed and no regular interval, so it should be atrial fibrillation. If they have written like this, they have not given you the strip, P waves and QRS observed but no regular interval, the answer should be atrial fibrillation, not ventricular fibrillation, because in ventricular fibrillation you cannot identify any rhythm. Okay, so this again answer is wrong. Patient present.
Sir,
Yes,
say something.
yes, please.
Sir, in fibrillation there will be no P wave, and in this question it is written that there is P wave and QRS complex, and there is no relation between Q and P, QRS and P. So it may be third degree heart block, I think so. Syncope also.
You know, actually in the word is, there is no, you are not able to identify the P waves in atrial fibrillation. Okay, so again this, your point is also correct, my point is maybe also correct. The thing is that you should be reading the whole scenario and then answer.
There should not be always there is no syncope in atrial fibrillation generally. Most of the patient, adult patient may have atrial fibrillation, mitral valvular patient have atrial fibrillation, but they don't have this syncope. Rather, they have palpitations.
Just a second. You are absolutely right, because they have, I actually, you see, I missed. I did not read here syncope. I was just reading here. So in syncope scenario, you are absolutely right. It may be, but again, I tell you, the scenario will tell you. Okay, the scenario will tell you, and such question should not come without ECG strip. If they have given you the ECG and then they are asking you the question, this makes sense. Without strip, only by words, it is not easily identifiable. Okay, they have written here, I replaced by short waves, then Q, again P wave. Yes, your answer, it may be third degree. You are right. You are absolutely right. Thanks for correcting. Okay.
Thank you.
So SVT, AFib already excluded on ECG. So shock will be given how much joules? SVT, how much joules are given?
50 to 100.
50 to 100. So again, it will be according to that, because they will give you some hint. It will be an adult patient. So SVT initial dose is, I think, 50 to 100. If it is biphasic, should be, I think, because atrial fibrillation, it is given more, 120. Am I right?
Yes, sir. 120 to 200.
Yes. Nerve stimulator works on which principle? Ohm law? I don't remember. I think yes. Anyone, any idea? Ohm law is about current and resistance. Am I right?
Yes, sir.
So I think yes, nerve stimulator. I need to reconfirm. I don't remember. Okay. Oxygen cylinder was given. It is through Boyle's law. Okay. And they should be calculating P1, V1 is equal to P2, V2. This is calculation by that. Magnesium sulfate overdose, drug of choice, calcium chloride. Okay.
Calcium chloride.
I'm sorry. Yes, this is also, answer is correct. Patient with history. Now after atracurium, you have noticed increased peak airway pressure and hypotension. It is due to.
Sir, if calcium chloride is the drug of choice, why we always use calcium gluconate in our practical setting?
Practical purpose, you ask yourself why you didn't ask this question. Actually, the thing is that calcium chloride, I think it is more irritant. It is better to use it with central line. This is the reason. And usually, if calcium chloride is given fast, it itself can cause arrhythmias. This may be the reason. But for practical purposes, you understand the theory why you are using it, you will never use calcium gluconate. You just need very less dose. Okay. If you are giving calcium gluconate, you need to give a higher dose. Okay. Actually, a number of Ghalatul Aam. Ghalatul Aam is so common, nobody wants to change it. Now in question number 46, again, I will tell you that atracurium does not usually cause hypersensitivity, anaphylaxis. So the answer is with histamine, the histamine will be more appropriate answer. If it is not written, then of course you will write this. Okay.
So which causes anaphylactic reaction?
Yes. Okay. I don't know what is this question. Wilms tumor patient after induction, how will you relax patient? 0.1 milligram per kg per hour. The dose you can see if it is, I think it is 0.2. Okay. Yeah, only the dose. 5 year.
So, sir, in books 0.1 mg per kg is written for bolus.
For bolus,
induction dose is 0.5 mg and maintenance is 0.1 mg per kg.
okay. Okay. 5-year-old child with epiglottitis, most appropriate step. Inhalation or induction? What is the answer? What do you think?
Sir, the patient should be urgently shifted to the OT, and in the OT, inhalational induction should be used for intubation. Sir.
Yes, actually,
we should not use muscle relaxant. Sir.
Baby will not allow you for awake fiber optic. Okay, so awake fiber optic is out, and the rest of the options will be out. So inhalational induction is the answer. But for practical purposes, if you have to be ready for even tracheostomy. Okay, because in epiglottitis you may not be able to intubate the patient. You may be needing smaller size endotracheal tubes. Okay. Patient was given succinylcholine. Most appropriate option. Homozygous atypical. Yes, it is a correct answer. Tunica intima layer lax. I have no idea about it. Tunica intima is the innermost layer, am I right? Intima adventitia is like that. Is it like this? Okay. During one lung ventilation, most effective method to avoid hypoxia is PEEP in ventilated lung, PEEP in non-ventilated lung, CPAP in non-ventilated lung, use of nitric oxide. What should be the answer? You know, actually the thing is that what is the first thing we do in one lung ventilation?
So we increase the FiO2.
Increase FiO2. Oh, okay. Then
check the position of the tube.
And later on, after checking the tube, we can give the PEEP to the dependent lung.
Actually, the algorithm you will find that CPAP will be before PEEP. Okay, so that is the catch if only these options are there. Okay,
sir, but this question is prophylactically. How to avoid hypoxia? This is not treatment.
Yes, no, I'm just telling you that because all answers you can think about it. Okay, because even you will give PEEP in the ventilated lung, you will give CPAP in the non-ventilated lung, you will be using nitric oxide. So what are the steps? Okay, so actually CPAP, or even if the option is there, even apneic oxygenation. Okay, apneic oxygenation is also an option. You just keep insufflating with oxygen. Okay, so you are absolutely right. This is to avoid not to treat. So avoidance is also a first treatment. Avoidance is the first treatment of anything. Okay. Patient with history of previous scar and placenta previa, he is increased risk of placenta accreta. Okay, fine. In empyema, there is fibrous changes, thus localizing infection. I don't know what they want to ask. Empyema is a localized infection. Yes, it is fine. Answer is fine. Upper, most probably for with upper RTI, it is 4 to 6 weeks, I suppose.
For lower respiratory tract infection, it is 4 to 6 weeks. Sir.
For upper, it is 1 to 2.
Yes, it is.
Sir, but if there are chances of there is risk of hypersensitivity in the patient, we have to delay for 4 to 6 weeks. 1 to 2 is for simple upper respiratory tract infection where there is no fever and no sputum.
Again, you know, if I remember, it is 4 to 6 weeks. Okay, but you reconfirm it. When it is 6% white per decade, it is also correct. We have discussed this in detail. Whenever there is narrow, there is turbulent. So turbulent, more on density. It should be, answer should be density, not viscosity. Agreed or not agreed? Flow of gases through alveoli depend on which law of osmolar, which law? What is that law? Graham's law? Who will answer? Is it Graham's law of diffusion? From high concentration to low concentration?
Yes, sir. It's Graham's law of diffusion. Sir.
Okay. Okay. In renal failure,
Sir, is not it a fixed law?
fixed law is also there. Fixed law is also there.
Sir, what? Usually, sir, in the alveoli, Laplace law is common, isn't it? Am I right?
No, Laplace law is for surface tension. They are talking about gas exchange. Actually, Graham's law is also there. Fixed law is also there. Both of them are there. But it is definitely diffusion. Okay. So it will be diffusion, not osmolarity. It is diffusion. Renal failure reason for coagulopathy is, it is qualitative platelet defect. Okay. Scoliosis surgery, sign of ischemia or SSC, decrease amplitude and increase latency. You know about it? The concept of latency and amplitude. In somatosensory work potential, there will be compression, there will be increased time in the response. So that is latency. And there will be decreased amplitude. That is the response. Okay. Patient with ball vibrant disease, most appropriate. You see, this will not be a single word answer. They will be doing it and checking it, the levels, and it is also depending on a type. I don't remember type 1, type 2, something like that.
Sir, there are 3 types. In
Yes.
type 1, we can give desmopressin.
Yes.
In 2, 3, we can't give desmopressin because in type 1, there is a quantitative problem. So by giving desmopressin, we can increase quantity of the von Willebrand factor. But in type 2, it is qualitative problem. So
Very
if we give desmopressin, they will only increase von Willebrand factor, which have a quality which function is not good. So there is no use of desmopressin.
Yes. So that is how you should be. Now this file is finished. So I will suggest you, whenever you are reading these questions, try to explore their answers, try to see that topic, try to see what are the like different options over there, because now next this question is axillary artery, you should be knowing the anatomy, otherwise you cannot answer it correctly. Okay. And this question, amniotic fluid, which sign happen immediately, sudden hypotension. Yes. Okay. So anyways, thank you. I just try to help you out as much as possible. Remember one thing, there is no shortcut. Aksa, I think she has left already. But I tell you that if take your time, don't rush up, explore the answers, clear the concept before you appear in the exam. Okay. Thank you very much.